To have success having physicians in your community is to train them in your community. They are more likely to stay in the community where they train. And so I would not overemphasize that enough to continue to grow your primary care trainees and residency programs in the local hospital so that those folks will want to stay when they're done. Same with nurse practitioners and clinical training in those environments. And I think really, the long game is starting to introduce our youth to healthcare, whether that's radiology technicians or nurses. But we need our youth to be excited about seeking a career, a path in healthcare. And so I love the program. And Dr. McHenry, I will applaud you and congratulate you. I've seen that presentation too many times to count, and that is the best that I've ever seen that presented. So I thank you for your wonderful presentation, and you're a resource for this community, and I feel your passion for what you're doing, so thank you. But I think getting Dr. McHenry in front of elementary school students and middle school students and the food program, and your colleagues and folks like you will create that energy around healthcare for the future.
I'd like to just, can you hear me? No. Try it again. Is this on now? No? Okay. Thank you.
I would just like to quickly add that I think it's not just attracting providers, but it's retaining providers. Provider burnout is a real problem across the country, not just in this area or in rural communities. One of the things that I do is I am, in my coaching, I work with a healthcare coaching institute that really is focused on helping to coach physicians on how do they continue to practice without losing their heart, losing their minds, losing their families or their balance. And so I think that, I agree with my fellow panelist in the importance of looking at the models that are there. And that's not just an Allegheny County challenge. I mean, that is across the board. And that really is not gonna fully change until the funding streams change, the reimbursements change. But that is starting to change. Medicare, specifically through CMMI, is starting to put a lot of programs out there that are focused on looking at the total cost of care and reimbursing based on quality of care rather than fee for service, where let me do this to you, let me run this test on you, and then, which for many years has been the driver of our medical system. And it's not sustainable. And so I think that in the midst of this transition of what's happening within our healthcare system, we really need to focus on how can we support those practitioners, those providers that we already have, and as we're trying to attract others, really focus on, here's how we do that. Here's the team that you're gonna have. So it's not just you, the provider, in a room, and you've got 15 minutes and then you gotta go on to the next one. That it really is a more sustainable model of care.
Wonderful, thank you. The next question is going to move on to hospital roles in the scope of care. Many respondents view the local hospital as primarily a transfer facility. How do you define the appropriate role of a community hospital? What national trends are affecting community hospitals that perhaps our community is just not as familiar with? And I'm gonna go to Dr. Just.
I may not be the right person to answer that question, being at a tertiary quaternary hospital. I did spend 20 years at a community hospital, and I think the community hospitals are expert at taking care of high volume community problems. And in fact, they may be better than some of the more academic institutions because they are there to take care of the more complicated, complex problems. And so I think that we need to focus on the basics, preventative care, and basic community acute illness. And we have a challenge as Dr. McHenry pointed out, we have lots of chronic disease that we need to treat, but at the same time, we need to shift more of our focus to preventing those chronic diseases. And so I think that that's an incredible role for the community hospital to play. It's a place where you want to go, and sometimes if you have a serious problem, you need to have that identified and then get to the right level of care. And so I would say I will defer to my other colleagues that are more active in community hospitals to maybe define what's appropriate for that. But having the resources to take care of the most common community diagnoses, I think is paramount. And then anything that you can add from there would be icing on the cake.
Anybody like to add anything to that?
Well, I know we could talk about this one all night. Try to be brief. I get this question all the time, and I know all of us do. This community has a CNO hospital and has a long and storied history of many medical practices and specialties, and I think we've seen it, erode over time. So I think that is felt by the community. So I think it's some of the underlying sentiment. Number two, in my 40 years in healthcare, I've seen physicians become more and more specialized. Like maybe some of you know, like Dr. Adralis, who used to be, I think he used to deliver babies, do surgery, do primary care, make house calls 24/7 every day, every weekend. They don't make them like that much anymore. There's some, but not many. And you look at orthopedics, they used to do everything, the Dr. Weidmans and McCoys of the world, knees, hips, everything, carpal tunnel, feet. Now they do maybe just knee or just hips. So if you're, and you mentioned this earlier, if you're doing this highly specialized procedure, it's hard to be successful in a smaller community. You go to bigger communities to do that. And so many of us smaller hospitals have to refer the need. My son had an ACL tear twice. And my general orthopedic surgeon said, you want him to go to a specialist, and that person's in Roanoke. So me as the parent said, well, I'm gonna go to the guy who does it 3 times a week, not 3 times a year. So I think that's a driver of this as well. I think we in the community hospitals do our very best to bring as much as we can here in Rockbridge, Bath, and Allegheny. Many of the physicians I talk to, I mentioned that Dr. Adralis type, many of them want to be in large medical settings where they have a urologist, a gastroenterologist. They want a team to call on. So if you have a pneumonia patient, a 90-year-old female pneumonia, but you're all alone as a hospitalist, you want to call all these people, and they don't always exist, so you end up transferring these patients where the physicians think they'll have comprehensive care. And I've seen this just happen over the years, but I've also seen every community I've worked in, they don't like that. They want everything here all the time on every corner. It's a constant conversation. OB is the best example. It's such a hard conversation. We talked about it. You gotta have the 3 OBs and 3 pediatricians and anesthesia 24/7 for epidurals.
Correct.
And then if
Oh,
you
and
have,
backup OR crew.
yes, and if you have a baby who's unfortunately born with an addiction because the mom is addicted, baby goes to Roanoke, mom stays here, and it's just a cycle, and it's such a hard conversation because everybody wants OB in their community. Hard conversation to have. I would say, building on those thoughts, you triggered a thought that I want to bring up, and that is how, I think the underlying sentiment is, how do we expand the services in our community hospital? And some are uniquely challenged, and others, I think virtual telehealth consultation is one way to start to do that, and we would love to have a conversation about how to partner to do that, where the specialist is not here, but perhaps could beam into the room and consult with the hospitalist first to say, is this something that's safe and best taken care of in the community hospital, or does this need to be somewhere else? And second, if we can take care of this patient here, what's the best care that I can make sure that we're providing for this patient here locally? And then if things get worse, can I get them to you or a place where they can get the care that they need? And so I think that's the sophisticated virtual consultation environment that we're going to have to cultivate over time through collaboration and partnerships.
I really like these questions and the responses, because I think that it opens kind of just a curious mindset, right? Because it's, why is this happening? You know, why can't we have this? And I think that it's not just the physicians, right? It's about the whole care team. If you have a nurse, back to these specialties, if you have a nurse who hasn't worked with an infant or, you know, any neonatal care, it's not just about the doctor being there, but it's also about the staff who's caring for the patient. Can they do it appropriately? Do you have the right things? Like, for instance, we have a CT scan, but we don't have an MRI, right? I will tell you that, and I'm sure all of the fellow CEOs will chime in, we have a transfer log, and I look at that transfer log regularly to say, are we transferring out patients that could be cared for in our community? Because we do want to do that. We want to work with our medical leadership to ensure that those patients stay in the community, because we do believe care closer to home is really our mission, right? But when I look at this transfer log, as Greg's mentioned, every single one needs a specialist, nephrologist, pulmonologist, cardiologist. And again, that becomes a non-sustainable service that we can't do. Now, I do love your comments there, Dr. Justice, in that this telemedicine component is going to be very critical. We've actually, you know, you have the stroke. So we have stroke on, you know, on demand. So when someone comes in, we think they have a stroke, we hit the button, we're talking to, you know, a physician who can say, here's what we need you to do, let's get the patient out of here. And we're looking at that for other services, right? Because those are the things that are important. It's not that the physicians don't want to do it, but they want to do the best for their patients. So if they have a cardiologist saying, you're doing everything you can for that patient, they're safe in your hospital, keep them there, that becomes a different conversation than, you know, oh, am I doing the best for my patient by keeping them at this hospital?
All right, let's move into affordability and insurance barriers. So more than 60% of respondents report difficulty affording care, with additional concerns about limited in-network options locally. What actions can be taken as a community to improve affordability and ensure that local services are accessible within common insurance networks? I'm going to direct that to Dr. Russell.
Oh, I could wax poetic for millennia about this topic. I think a couple of things as far as in-network. I'm actually not familiar with who the primary payers are here, because again, depending on the major employers and things. But I do want to talk about that a lot of hospitals, especially smaller hospitals, the majority of payers are Medicare and Medicaid, right? That ends up being the combination. And literally they pay you about, on any given day, 65% to 75% of the cost of care. So what a lot of hospitals do is they look to the commercial payers in that small percentage to help kind of balance the books, right? To make sure that they can basically continue to operate. And so you sit with these insurance companies and they basically will, you know, and especially if you're a small hospital, you don't get the best deals like, you know, someone like HCA where they have, you know, national network power, they're probably getting better reimbursement rates. And you can actually see that now that we have to post all of our stuff online with we're getting paid by insurance companies. So if you actually want to go out to each of our websites, you can see what we get reimbursed from Aetna and, you know, other payers for a certain type of procedure. And if you look, because I look regularly now, Bath Community Hospital is woefully much smaller than some of these other hospitals. And so what happens then is you make these deals with them, and then they do things like automatic rejection. And then a lot of these hospitals have to hire people to fight these rejections, right? And if you're a small hospital, you don't have the manpower to do that. So it just becomes this vicious cycle where the community says, how come the cost of care is so high? Well, one is because you have to hire all these people to deal with the rejections of the insurance company or call for prior authorization or make sure you're doing a peer-to-peer. So now you're tying up a physician's time to have a conversation with another physician and insurance company rather than see patients. And then again, well-meaning, intentioned regulations from CMS, but also causes that burden of having to hire more people to ensure that you're following that. And so when they look at hospitals, and and I'm not saying that, you know, hospitals are innocent and all this. I think all of us in the American healthcare system have a part to play in being more efficient and looking at how we're providing care. But I think that what you can see across the US, and if you look at these numbers of how many rural hospitals are shutting down or going to a system. Frankly, Bath Community Hospital is the only hospital, critical access hospital in the state that's independent. And that's frankly due to a foundation that we get from Letty Pate Evans every year that allows us, because our operating margin is negative. And so with this foundation, we're actually able to stay in business. And without it, we would have either had to go to a system or we would have had to shut our doors about 10 years ago. And so I think it's an extremely complex topic. There's not one answer to it. But I also want to talk about affordability, because again, I think a lot of people don't realize that the resources are out there. And again, and I know sometimes it's really hard for people to ask for help, and we're really trying to normalize this conversation. Lori Hicks, who many of you know, is in the audience, and she has done a lot of education with this, with our community members, saying, you know, it's not charity, it's not a handout. This is you know, available to you. All of our hospitals, you know, for nonprofit have to have a sliding scale. We have to have, you know, and even Dr. Tucker talks about it. What they call basically their community payback is, you know, charity care. I mean, that's really what that is. And so people need to, I think, realize that the hospitals are there for them. There's, you know, again, I know that there's a stigma, but they've got to get past the stigma and go talk to the financial offices, because there are resources there that can help you, as well as other things outside of the hospital. There's lots of community foundations and things like that that will help with your bill. So I think if you can take anything away from this, is if someone feels like no one should lose their house because they had to seek health care. No one should, you know, lose their car, their livelihood. This is something that we can help with, and so you should definitely be encouraging people to go talk to their patient financial services.
I don't want to pile on the unsustainable nature of the current system, because we have to change. And this comes back to my prior comment about we have to find new ways to do these things. And one of the reasons that I went back to UVA 4 years ago was to be in the presence of young minds that are thinking differently about these things, different perspectives, and lifelong learners, and it's been inspiring for me. So Capstone Project presented yesterday is how do we deliver healthcare at the Dollar General? And just think about that. There's a Dollar General in most rural towns in America. And so imagine a kiosk in the Dollar General. Imagine your prescriptions being delivered to you at home in 24 hours. Imagine a $30 primary care visit at CVS or at Kroger, or one of these places where we don't have to build a building. What are the expenses of healthcare? The providers, the staff, and the overhead of the building and the operation. So if you've got a building in every community in America, like a Kroger or CVS or a Dollar General, let's figure out how to get healthcare to that place where the people go every day, and figure out how to get the cost of drugs delivered to them in a way that's affordable. And so I think, I don't know how to execute on that yet, but I'm excited and inspired by the idea of thinking out of the box and how we can get away from, will there still need to be surgical offices? Yes. Will there still need to be radiology suites? 100%. But not all of the care needs to be delivered there. And I think there's a cheaper way, more affordable way, more common sense way to deliver health care. So I'm excited about exploring that in your community. If this is something you want to try, let's get together, talk about it, and figure out how to do it.
Maybe just a couple footnotes on this topic. I think it's really important to emphasize what you said, that most hospitals, if not all, lose money on government payers. And this is a government payer town. And you make it up, hopefully, on some commercial. So 55% of Medicare members are now on Medicare Advantage. And it gets to the rejections or the provider, the denials, which we have teams of people, physicians, that would pay physician salaries to find insurance companies to get paid for legitimate care. And a couple other things that you should know that should be on your radar screen that's recent. So you've heard of the Affordable Care Act. You've heard of the subsidies that went along with COVID that no longer exist anymore. So those people are not renewing their premiums and they end up in our hospitals as uninsured, meaning free care. Carillion Clinic, over $100 million in free care per year. It's a huge number, and it's only going up. And then in the HR1, the big beautiful bill, Medicaid patients will have to recertify twice a year and have work requirements. That's going to create more uninsured and less Medicaid. And that means Nicole, Jane, and I are going to have more uninsured and less Medicaid. So there's this compression of revenue to the hospitals, which are the main employers of physicians and advanced practice providers, creating this friction. I just wanted to kind of highlight those pillars.
So I just want to add that, and I don't disagree with it. I agree with everything that these folks that you all from hospitals have said. I also want to emphasize that prevention is a lot less expensive. It is much more affordable to prevent a health crisis that leads you to the hospital. The hospitals will always be necessary, but much to the presentation earlier, if we can emphasize more the prevention of some of these issues that lead people to need the specialist and lead people to need the hospital visit, things like all the prevention things that were in that presentation. The other thing that I think somebody had mentioned, I think Sandra had mentioned, the caregiver strain. So when someone has a chronic illness, the strain on the caregiver. One of our programs is working with dementia and supporting the caregivers of those folks with dementia, because we know that the caregivers are also at risk of isolation, mental health issues, stress, high blood pressure, stress eating, all of those things. So if some of the focus can really be shifted, and I don't know if shifted is the right word, because that all needs attention as well, but I think that the more that we can focus on prevention and early intervention, that's going to help the affordability issue across the board.
All right, I'm going to combine the last two questions. I'm going to start with Ms. Walsh. This is about future outlook and collaboration. Many residents expressed concern that access will worsen over the next 5 to 10 years without intervention. What does a sustainable and accessible healthcare system for the Allegheny Highlands look like in 5 to 10 years? And how can your organizations work together with us to help achieve that vision? Also, I would like to know what is one immediate change within the next 12 months that would significantly improve healthcare access in the Allegheny Highlands?
I start with the big thanks. I think that, so I'm going to start with like the next 12 months and then leading into 5 to 10 years, because the 5 to 10 year vision really, I think, does come down to the system needing to change. And I think that there are signs that that is starting. And I think that we here in our local communities can continue to talk to our representatives about what's important, about what's challenging, to reinforce things like the rural health transformation. Virginia had a whole rural health commission going on for the past couple of years. So we can continue to let people know that this is an issue, this needs to change. I do believe that some of the new payment models that Medicare is initiating, where they really are looking at total cost of care, they're looking at reducing readmission rates to hospitals, reducing mortality rates in the hospital, so and increasing the focus on advanced care planning. Greg, you gave an example of a 90-year-old with pneumonia, being shipped off to a hospital in a different town. Did that 90-year-old really want that? I think those are some of the really challenging conversations that we have to have that most medical professionals are not trained in. They're starting to get trained in that. But that really, I think, can be be part of the focus. And so for the next 12 months, what I would say is that really looking at how can we help educate folks around the prevention pieces that will reduce the need for those specialties, help people focus on what does a quality of life really look like, and at what point. And this is a hard conversation. It's a hard conversation to have with yourself. It's a hard conversation to have with your family. It's a hard conversation to have with the medical professional. But it is probably one of the most important conversations to have. It's like, when does quantity of life versus quality of life reach that balance where let's not fly Grandma to Roanoke because she's got pneumonia. Let's get Grandma home so we can all get around her for our last Christmas together and keep her as comfortable as possible. The other piece that I think in the next 12, well, this may be longer than 12 months, but 12 to 5 years, is that I think that in rural communities, one of the things that, and I think you mentioned this, is that a lot of times it's not necessarily lack of access or knowledge or being able to get to the doctor. It's what do you do about what the doctor tells you to do once you're home. It's accessing the good food. It's knowing how to, how to get the particular medication that they want. Or they go to one specialist, they have this medication, another specialist says this medication. Those two medications don't always go together, and they don't have somebody telling them those don't really go together. Which then creates a whole other issue. So care navigation, I think, is a new piece of the healthcare mix that really can be very, very helpful, and can be done by folks that have good hearts and good minds and don't necessarily need a medical degree. Community health workers, those types of the paraprofessionals. I love what you said about connecting with the EMS. And I think that is something that this community could really focus on in the next 12 months, 5 years, that could make that 10-year picture so much better for so many people. And I just also want to say thank you all for being here, and thank you for hosting this. I didn't say that when I first started speaking, so that's.
So I really liked what you said about, rethinking things. And so back to the care outside of the hospital, right? We all know that only 10% of someone's health is what happens in the four walls of the hospital. It's outside of the hospital that shapes the majority of who we are. Now, you can't outrun genetics and things like that, but there's a lot of things you can do to fix that. And so I want to highlight a few partnerships that we're looking at, because that's our goal, right? So Bobby spoke earlier, and we're partnering with the schools in Bath County and the YMCA to bring an after-school program into our community. Right now, there's two issues with that. Is that there's no after-school care for children in our community, and so we have a lot of employees who struggle with that and can't necessarily come to work. The other component is the YMCA does an amazing job of not only helping them with schoolwork, but also helping them with activity, with other things of learning. There's the, Bobby, you're gonna tell me this, the food science program, what was that called?
Dr. Young. Oh, Dr. Young.
Oh, Dr. Young, yes, so Dr. Young's program. And then the other thing that we're looking at, Lori's in the audience, and many of you know Lori Hicks, and she's been the marketing director at Bath, but she actually has a new title. She is the Director of Population Health and Community Outreach. Because again, that's how we're going to improve the health of the community. It's not going to be the hospital doing it. And so Lori is launching the Food is Medicine program. We are looking at a community garden. Not only that, but how can we get people who are elders in the community to help us with that? So again, the isolation component, partnering with making sure that school-age children, multi-generational groups getting together so that they can learn from each other. And really, those are the components that obviously we need to continue the care in the hospital, but we're really focused on that. And I think that the work that the county's doing here with making things more walkable and, you know, the community health improvement plan, those are the critical things that are going to improve health over time. It's not going to be us in the hospitals. We may improve the way we deliver care and you know, I think again, people need to understand that. And it's hard, right? We all are there, right? We stress eat, we do all those things. I mean, we're human beings, so we know the difficulties, but if communities can make it easier to do the right thing, I think that's really how it's gonna help us in the future.
I know the hour is running thin, so I'm just gonna convey one last final point. I've said it before, but I'll say it again. I think it's really important that we be focused on health policy. Go to the American Hospital Association website, the Virginia Hospital Association website, sign up for legislative alerts. I know many of you come to the town halls we have in this theater with Cree Dees, Terry Austin, Ben Klein, Mark Warner, all of them. And if we are informed about health policy votes coming up, let's hold them accountable when they come here and talk to them about how we feel. I went to Richmond at least 3 times this year to advocate for healthcare policy. It's a complicated process, but we are majority government funded. That's a kind of a hospital-centric comment. But what they do in Richmond and DC incredibly impacts what we do here in the Allegheny Highlands. So I just stay informed, and I know we will, and will be a voice in the legislature to advocate for good, sound healthcare policy. But I do agree with Tasha. I do see signs of change. There are things brewing, and when a product becomes too expensive and the masses can't afford it, it causes change. So, but thank you all for being here as well. I appreciate the opportunity to be here.
I'm trying to be brief, but I have a lot of thoughts about this. The financial pressures that you've heard tonight are only going to get worse in the next 12 months, 5 years, 10 years, all those time frames. So, you know, I think that we will continue to have to deal with that. So resources are not going to be more available. They're going to be less available. So how do we manage that? And I think it's partnerships. I think partnerships and this, I think, is a great idea for cultivating partnerships. No one entity, group, community can do this on their own. And so we have to get together and strategically plan how to coordinate resources within the community that already exist. And then do a gap analysis on what resources don't exist and how do we connect with those. So, you know, part of the strategic plan and part of the mission for UVA Health is that we are deeply committed to making the health of all Virginians better. Now, we can't do that on our own tomorrow, but we want to talk about it. Call us, let's sit down, let's figure out where the right partnerships are to help your community take the next step. Is that virtual care? Is it technology? I think technology in the next 12 months, technology and primary care are the 2 things to focus on. Can I imagine a world in 5 to 10 years where industry has supported memberships for everybody in the community to go to the Y, and the Y become the hub for the education, for food, healthy food distribution, for exercise? I think you have a fabulous, I've known your Y now for 2.5 hours, so I think from what I know, it's a fabulous place to start. And it fits with your goals of wellness and a healthy community. So I think the Y is going to play a role. I think the hospital is going to play a role. I think your existing doctor's offices are going to play a role. I think CVS is going to play a role. Hopefully UVA Health can help play a role. And we don't want to compete with the resources that you already have, but how can we supplement? How can we bring specialists? If you need pediatric specialists, how do we get them connected to your pediatricians so that we can provide that specialty care close to home? I think we've done that successfully across the state in many places, and we would love to continue the conversation here in Allegheny. So thank you for the invitation. Thank you for the innovation and the creativity and the commitment to your community.
Well, on behalf of the county and the community gathering group, thank you all so much for showing up and for giving us such wonderful insights into what you do and how we can improve and make lives better for everyone in the county and the Allegheny Highlands in general. So thank you all so much. That concludes our forum. Thank you. We actually have a whole different